But welcome everyone. Thank you so much for joining for our monthly call. Um, we're going to probably just dispense with introductions since we've lost about the first few minutes. We've got our honored guest here today, Ed Weisbart, who I was thinking about Ed this morning, and I landed on thinking about Ed as the Walter Cronkite of the single payer movement, probably the single most trusted voice and analyst in our movement. And I have to say, I've had the pleasure of getting to know Ed more recently. I think it's sort of ships passing in the night, so to speak. But certain issues have popped up recently, and we've gotten to know each other better. And I really am grateful for that, Ed. Your temperament, your thoughtfulness, your purposefulness, and your strategic mindset is so welcome in this movement. And looking forward to working with you and Phil and Ed, and really fusing our efforts even more intentionally with One Pair States and PNHP. We have so much in common, and we have so many fights that we need to win together. And we are that much more powerful with you in this fight. So thank you for being with us today. We'll go for roughly half an hour. We have some business to take care of on the back end. I think Mike was trying to clarify that a little bit with you, but I don't want to hold off on any further time delay for you. We need to bring folks up to speed on what we're doing right now at this moment. So Ed, thank you so much for being with us. Based out of St. Louis, imagine you're in some summer swelter as well, but I'll let you take over right now and roll out with your presentation, and we'll open it up for some questions after maybe 15, 20 minutes. Does that sound good?
Yep, great.
Okay, thank you.
So I'm going to shock you all, and I'm not planning to use slides. Don't be afraid. Don't be afraid. So yeah, when y'all reached out to me, I thought the timing of a chance to talk to you today is really terrific. There's so much going on, so many things that are planned for the next few months that much of it you've probably not yet heard of. So, and much of which I would very much hope you find um, um, productive enough that you're going to want to engage full throttle on it, because there's a whole bunch of things that we want to get moving. So just to kind of get started with that. In case you don't know me, I'm Ed Weisbart. I'm a retired family physician in St. Louis, and I'm the National Board Secretary of PNHP. So, yeah, really Walter Cronkite. The Walter Cronkite. It's a first. Okay, so first of all, of course, the whole purpose of PNHP and of One Pair States and of several of our close allies is to accomplish universal, comprehensive, healthcare for everybody. And most of us think the best way to do that is through a national single payer program built on Medicare. And there are many different pathways to get there, but that's the goal that I think we all largely agree about, which means that the first priority that we're going to have to be focused on next spring will be to build more co-sponsors again once the single payer legislation gets readmitted to the new Congress next year, which we're confident it will. But it's naive to think that that bill, as important as it is, and as many more co-sponsors as we want for it, and will hopefully acquire, it's naive to think that under either president that's likely to win the election next year, and probably under much of the Congress next year, it's naive to think that that's going to actually pass in the next 2 to 4 years. So a whole host of other things needs to be happening, basically foundational kind of work. And that's where we've decided to focus on this. It's a target-rich environment. Where do you focus? And we've decided profiteering and privatization is in addition to passing Medicare for all, privatization and profiteering are some of the biggest things we need to combat. And along that line, Medicare Advantage, as you probably hopefully agree, and I'm sure have heard, Medicare Advantage seems to us to serve as a poster child. So for that, so rather than trying to spread our resources across a million worthy targets, and there are from every bit of healthcare right now, we decided at PNHP to focus most of our work on combating privatization and profiteering through fighting Medicare Advantage. That's kind of our strategy at the moment. And I'm here to tell you, literally here to tell you, that the next few months are going to be a very busy part of that campaign. We're entering a very busy season for that. So we are focused on open a number of activities around open enrollment of 2024, trying to get an early start on that. Uh, we're focused as well on right after that, the 2025 rate hike proposal that we know CMS will do again, as they do every year in the spring. And so we had a pretty successful first major salvo for the one this past spring, and we want to amplify that and be more assertive and organized for the 2025 CMS release of a proposed rate hike, which will be the 2026 Medicare Advantage rates. So we're thinking longer term than we have often in the past. And then on top of that, of course, right on the tail of that, as soon as that process is completed, we want to redouble our efforts on the 2025 Medicare Advantage open enrollment season. And I'll show you some connections we're trying to build between the 2024 and the 2025 campaigns. And then, of course, mixed into that, whenever it happens in the spring, is the campaign to get more co-sponsors for Medicare for All bills. So first and foremost on that list of 4 topics: open enrollment 2024, Medicare rate adjustment in the spring of 2025, open enrollment 2025, and Medicare for All bills. Those 4 things, first and foremost, is, of course, the 2024 Medicare Advantage or Disadvantage open enrollment season. And our goal for this year's campaign against Medicare Advantage open enrollment, our goal is to really primarily to change the national narrative about Medicare Advantage. So in years past, most of the journalism that surrounds the hooray open enrollment is here. Most of the journalism around that has been sort of fawning and positive, or at best presented as, be sure you get updated or check your options. It's not been terribly critical. And this year, going into open enrollment, we have 2 sets of tools that we didn't have in years past. We have the report that I'm sure you've seen from PNHP demonstrating tens of billions of dollars of subsidies that these corporations are getting. And so we didn't have that information last year. And then we also have this new report we released a few weeks ago showing the harm that these corporations impose on tens of millions of Americans. So with those tools, we're hoping to change the narrative that media uses when they discuss this. And so how do you do that? Do you just sit in your room and think, let's change the narrative? No, we've got a bunch of very specific things to engage, that we want to engage everybody with, which is why I'm so glad you invited me today. The first piece of that is in less than a week, and I'll put up a link to this in the chat when I get through blathering here, but on Wednesday, June 26th, so next week, at 5 o'clock Pacific time, 7 o'clock my time, 8 o'clock p.m. Eastern time, at Wednesday, June 26th, our good allies at Be a Hero have organized a training program for folks who want to ramp up their skills at public outreach regarding Medicare Advantage. I don't know if you're very familiar with Be a Hero, but they are strong allies. They are very aligned with a single payer approach, and they're organized. They're hand in hand with what we were saying about Medicare Advantage campaigns. So the Wednesday, June 26th training is oriented towards sort of public outreach, how to speak at farmers markets, what to do there, and other places, stuff that I'm sure a lot of folks on this call have had experience with. So you can, contribute to this, and I'll put up the link for it. We've had a bunch of people. There's well more than 100 people already signed up for this training. So that's the first piece, coming Wednesday. And then sort of along that same venue, PNHP is planning to ramp up our speaker training for more traditional PNHP type speaking gigs. So how to speak with physicians about Medicare Advantage, how to speak with senior groups, and a variety of other groups. So that we're ramping up that training. It's getting developed much more robustly than we've done it in the past. I can't give you a specific date for it, but I will post a link where you can sign up to be kept up to date on that. And that link will have a whole bunch of other tools and actions that PNHP is helping organize with our allies. So I'll put up that link in a few minutes, and then you can add your name and you'll get told about all that stuff. All of this, what I just described, as sort of training and organizing stuff, but the action, more direct action, is we're delighted that there's going to be a day of action on Monday, September 30th. And there'll be more information about this too, but this is your first, perhaps, heads up about it. Monday, September 30th, we're hoping to have a series of actions aimed at exposing the hazards of insurance companies, using those two reports and other material with a whole bunch of supportive stuff. New York City Metro is expecting to have a pretty large public event on that Monday, September 30th. It's obvious that not every place in the country is going to decide that a Monday is the best day for them to organize on. And that's frankly good. So we're hoping places will organize around, Saturday and Sunday and sort of have a few days of action. Machiavelli told us to sprinkle things like that out, not do them in one single bolus. So, if there's a day of action on Saturday in Portland, they'll hear about that in New York when they get their news, and the day of action in New York will get reported in Dallas, and hoping that having a cascade of these will be more effective, frankly. So, if the people on this call think this is a great idea to have a day of action and you want to do it on Monday, September 30th, that's great. But if you decide that that's really something you need to spread out more, that's great too. So the reason I'm talking about this with all y'all today is it'd be great if people from the one payer states could help kind of pump folks into the Be a Hero event for those who would benefit from that, to the speaker training, to the days of action, and all the other stuff that'll be on the link that I'll put up in a few moments. So related to that, after the organizing event for open enrollment, then we'll be ramping up for the Medicare Advantage rate adjustment piece. And as you know, the only reason we were able to hold Medicare Advantage rates to the level that we did is because we had loads of people around the country speaking with their representatives and speaking with their senators, and lots of organizing events that took place, and we got some real success from it. They didn't CMS held to their initial rates, so we're hoping to kind of learn from that and amplify that even stronger to have more success next year. That's early in development, and then right on the tails of that, to do reorganizing around the next open enrollment in 2025's open enrollment period. These things are wedded together in that we're hoping to craft messages for the 2024 open enrollment season and promulgate them in a way that we can actually test, so that we will know which ones of these are the most effective, which strategies are more effective. So we're viewing 2024 as sort of a beta testing of lessons that we've learned from previous open enrollments. And we're hoping to do that in a rigorous enough way that in the 2025 campaign, we'll actually have data-based, more sophisticated messaging strategies. And then, of course, sprinkled through that is whenever the Medicare for All bill comes up to get more and more co-sponsors. So a couple of other things to kind of hit. You've probably heard about sort of the strategy of leveling the playing field. Several of you have been actively involved in that. And the notion there is to really make traditional Medicare something people can opt into, to try to slow down and hopefully reverse the rapid growth that we're seeing in Medicare Advantage, profiteering and privatizing from all of the, from Medicare itself. So we're hoping to slow down their growth and expose things by leveling the playing field between traditional Medicare and Medicare Advantage. And there's a whole bunch of pieces to that, but one of which is not yet completed, but I'm hoping it'll be done soon, is have an actual bill in Congress. So it's we're pretty near that being done. And the bill, if it's the way we're hoping to do it, would introduce across Medicare a maximum out-of-pocket payment of $1,000, a maximum out-of-pocket payment for $1,000, which then end runs most of the need to talk about Medigap and guaranteed issue and community rating. If the out-of-pocket maximum is $1,000, and states that have expanded Medicaid would have most of the folks under that level be in dual eligibility. I think that's a big piece towards leveling the playing field. And then, of course, embedding as a core benefit design in all of Medicare, a good hearing, vision, dental, and pharmacy benefit. The idea being that, number one, those are important benefits that you shouldn't have to give up traditional Medicare and go into Medicare Advantage to get. You should be able to get them by using for anybody in traditional Medicare and have it be simple so that if you go into traditional Medicare, you don't then have to shop for Medigap because there's a low out-of-pocket max. You don't then have to shop for pharmacy because there will be a pharmacy benefit embedded in Medicare. So have it be as simple of a process to go into traditional Medicare as the Medicare Advantage corporations have made theirs. Then there's a whole range of other sort of structural pieces that we've been constructing that we think would also add to the level of the playing field. So that's a bill that's in active development by a number of our allied friends collaborating and conversations with members of Congress and their staffers, and we're hoping soon within the next month, and maybe sooner than that, to have something more specific to report on that to you. So it's at this point, there's no action that you really need to or frankly can take about it, but just going to be aware that it's coming up. So the action requests are to recruit people into the June 26th Be a Hero training, to help us recruit people for the PNHP speaker training, and organize around the September 30th piece. And that is my and I can't tell you who are the co-sponsors that we're working with. It's premature, and I can't speak out of school about that. But I can tell you the organizations that are working with us on putting this together. Be a Hero has been huge. Social Security Works, Public Citizen, Just Care, and a range of others. People's Action. So it's not finalized. So I can't say that any of us or them are, owning it, but hopefully pretty soon. So.
Terrific, Ed. Thanks so much. It's quite a bit to chew on. Why don't, let's see. Yeah, I was going to ask the same question about the legislators you're working with. You need to keep that under wraps until it's more formal. I get that. Let's see. The day of action on September 30th, again, that's designed to expose the insurance industry predatory behavior, right, around Medicare Advantage, correct?
Yes.
Specifically,
yeah.
okay.
I would expect that every group that does one of these would take a different flavor, a different emphasis. But yeah, the basic message is we're doing these because we want to change the narrative around the country about these things.
Right. And then you're going to drop links for signing up for Medicare Advantage training on June 26th, correct?
I just did. It's in the chat.
You did, okay. Awesome, beautiful. And then for speaker training, is that for PNHP members, physicians only within PNHP, or just anybody who supports single payer and wants to be part of a speakers bureau?
I can't give you an answer to that today. I think it's more broad than just for physicians. It's certainly not limited to PNHP members, although please join PNHP. But it's not. So if you go to that link that's in the chat now, there's a range of things you would be able to check off. I'm interested in this, and this, and then that would get you on the list. And for each of those things when the details come up. So you'll get more information about that.
Awesome. Okay, let's open it up for questions for Ed. Folks, let's see. We've got Bill Semple out of Colorado, Boulder, Colorado. Bill.
Yeah, unmute. Okay, thanks, Ed. Really helpful. I'm wondering, I read from what Wendell Potter says, is that the Medicare Advantage companies have been taking a hit in the last quarter or two financially. And can PNHP PNHP take some kudos for that? That they're already changing the narrative so that the Medicare Advantage companies are less able to game the system quite as well as they have in the past?
Um, PNHP and its allies. So, one pair of
Mm-hmm.
states did a lot of work on this stuff too. There's a lot of overlap, of course, but the ally organizations that I just rattled off a moment ago, they've been involved in it too. But yeah, I think it's our collective organizing that's absolutely responsible for this. CMS. I mean, the piece, the most prominent piece of this is that the Medicare Advantage rates did not go up above what they proposed, which is the first time that that's ever happened. So 2 years ago, there were just 3 or 4 people that were communicating with Congress. Wendell Potter and a few others, Diane Archer, were communicating with CMS and begging them to not go above the proposed rate increase. It was just 3 or 4 people. There wasn't an army, but we all kind of got wind of what they were doing, and so this past year we had dozens of meetings. We had, I think, 46 meetings with members of Congress, most of which were led by PNHP, although our allied organizations have led many others too. There were tens of thousands of letters, and I don't know how much, stuff, but there was a huge campaign yeah, and that's why I think, and Medicare has said that they make those rate proposals and they think those are the right rate proposals and they don't want to go up beyond that, but then they get deluged with pressure from industry. So having groups like ours, by ours I'm including one payer states, having groups like all of us, communicating about this and showing CMS that we have their back. We have their back. Hold the line. We're watching. If you increase the rates beyond what you said, we're going to see that, and you're not going to like having the public outcry about what we can organize these days. So yeah, I think we can. I think we can do. As a collective group of organizations, we should pat ourselves on the back and then use that to go further.
Okay. Good, Ed. Bill, thank you. Let's see, Malia, where are you from? Malia, you're up next.
Yeah, I'm from Los Angeles. I've also put a couple things in the chat. So Ed, I'm also a member of PNHP. So will PNHP be creating a banner that we could put like on a table when we go to markets, and then when we also go to the September 30th or the weekend prior? And then also, have they thought of a catchy slogan?
Banner is definitely on a table. Banner is on the table of things we're thinking of making available to folks. So I can't say that we've nailed down all the supportive materials, but we've definitely been thinking about that. It would be handy for people to have that. Catchy slogans, those are so hard, right? I mean, they're so hard. So I mean, we've trotted out a bunch of them. I'm sure you have too, but I mean, if you have a great idea for what that should be,
I'll think about it.
yes. And I'm sure when we unleash more of the campaign, there will be some catchy slogans, but and that's part of what we want to test. That's we're actually we're hoping to be able to get a grant to genuinely test which slogans are more or less effective. So at this point, it's anecdote and what we think. And the reason I'm saying it like that is because I'm here to tell you, having spent most of my pre-PNHP career in industry, they don't rely on anecdote. If they put out a message, it's been tested and tested and tested. And so they use science and we use anecdote. So we're hoping to kind of advance the discussion beyond that going forward.
I also want to do a shout out for PNHP. At the last meeting, there was an idea about going to MA meetings where the insurers are pitching it and asking sort of pointed questions like, oh, I've heard there's fraud, or, oh, if you get a cancer, can you go to, whatever position you want? And, oh, you can't get out after a year in most states. And I got to give a shout out to our new Walter Cronkite that Ed actually played the insurer. And at one point, he actually broke a roll and just cracked up. It was, if you have a chance, I think that got videoed. If you have a chance to watch it, it's It's marvelous.
You were there. It was a fun day.
It was.
Good. Well, so the Walter Cronkite image may stick after all, Ed. That'd be a good one. But before getting to Diane, I do see a question in the chat from John Rickard. What is the present CMS rate? Do you see that?
Yeah, I don't know that I have an answer for you other than to say way the heck too high. I mean, there are numbers around that. I don't have that at the tip of my and it's the benchmarks are, of course, sort of based on a whole calculation, the whole methodology. It's not there isn't like it's $1.50. I mean, it's the methodology that creates the benchmark for each MA company or corporation is a better word. Let me just for a moment do that little dig into the word company versus corporation. Our communications experts at ASO Communications have told us the word company sounds friendly, like, mom and dad, or we're having company over. And corporation just, is really what they are. They're incorporated, they're corporations. And that's not as warm and fuzzy a word. So as often as we can, I try to move my language over to MA corporations rather than MA companies, insurance corporations. Anyway, it's hard to get that discipline, but
well, another one, and I will get to Diane, is using profit first as opposed to for profit, right? Because their business model, they bake the profit in before a single healthcare service is paid for. Profit first is a frame that I've tried to get pushed into our movement for a number of years. Profit first. Diane, where are you from? And you need to unmute. Diane, Lucas?
I'm here. I'm in Oregon, Chuck. And just a quick comment. I think we should use something really simple as a slogan, such as "Don't be fooled." That's all.
yeah. Yeah, I like that. I like that. I like the profit first, framing. I think there's going to be a lot of different right answers. It depends to whom you're speaking and what your background is, what you're comfortable saying. And it's got to be, but it's tempting to think we should all use the exact same mantra because repetition really kind of helps on things. But I think the diversity is also good. So probably a blend. Some parts. Don't be fooled is good. I like that.
Anybody else have a hand up that I'm not seeing? You can just shout out. I have a couple questions also. Michael Bacon, I saw your hand waving and then you disappeared.
Yes, I don't know how to wave my hand otherwise.
Okay.
I've read both of your reports, which are excellent, and I've read a lot of letters to the editor, and they're a great resource to have. I did have one question about how should we be viewing the nonprofit Medicare Advantage plans? We kind of accuse them of profiteering by definition. I'm thinking of, for example, Kaiser Permanente, which is seems to be highly regarded. And I'm wondering if we should be making an exception for organizations like that. As I understand it, they're sort of a combination insurance company and medical practice sort of rolled into one. Yeah. I guess that's vertical integration, which I guess some people say is bad, but I'm wondering if in this case it is. What are your thoughts on that?
It's tough, the numbers, the information we have about Medicare Advantage writ large is writ large. It's average and summary total data. And one of the problems of that is that, of course, there are, I'm sure, better and worse Medicare Advantage corporations. There are some that are better and some that are worse. How can that not be the case with averages? And there's very, very little meaningful public data to help anybody identify which one is better versus which one is worse. So people often ask me, well, what about this one? There's no information basis for that. And I think a lot of us do have the experience of some that are not as bad, but we don't know that. So I think a lot of folks do tell me that Kaiser, and there's no Kaiser near where I live, but I have had a lot of folks tell me that Kaiser is one of the ones that they've had better experiences with. There's an MA firm in my area that a lot of folks have told me they've had better experience with. So there's no information to make that assessment, but what I keep coming back to is that the fundamental model, the fundamental business model where they're prepaid based on a very gameable system. And then once they're prepaid, every penny that they let go out of their grip into paying for our care is a loss. They actually call it a loss. It's a loss. And that's fundamentally screwed up. That's a fundamentally screwed up way to do it. So are the nonprofits less egregious than the for-profits? I've worked in both, and my personal life experience in both is that it's an almost invisible difference, except that the for-profits are focused on the quarterly returns, for their their investors, but they're both intensely focused on maximizing their profits or minimum or whatever they call it. Nonprofits don't call it profits. So I'm not persuaded that there's a huge difference other than sort of the tax implications for them. But on the other hand, part of how we got into this whole scenario was to create an exception for groups like Kaiser that had a good reputation. So should the final solution be one that has some, I don't think so, because I think this whole prepaid model is a disaster. But I don't think we have the complete answer to that, and I'll stop blathering.
Okay, thanks, Michael. Is that good?
Yes, thanks a lot.
Okay,
Yeah.
thank you, Michael. And Diane, I think were you finished as well, Diane? Or you had another question?
Yes, I just wanted to say this is another instance of don't be fooled. Kaiser Permanente is not really a nonprofit. It's a conglomeration of for-profits and nonprofits, and it's becoming increasingly privatized over the years. And as somebody who's been in it for a long time and been thrown out of the hospital because they couldn't find me in their database, and on and on and on and on and on, it is not functioning like a nonprofit. I would have to have an income of less than $20,000 a year in order to qualify for help with my Medicare. And right now I'm paying the majority of my Social Security check for care at Kaiser. Kaiser buys a drug from Amgen for $2,400 a month. It bills Medicare for $4,400 a month, and it bills me for $700 a month for that drug. Nonprofits do not function like that. Sorry. Don't be fooled.
Yeah. Okay. Thank you, Diane. Let's see. We've got Malia and then Richard. Is that Dick Gottfried from New York? And then terrific. Great to have you with us. But Malia, you've gone before. Let me just jump over to Dick and come back to you if that's all right, just so that we get everybody in. And we have to wrap this up in a few minutes. And I have another question related to the election, Ed. I don't know if you think in framing this around this upcoming election, it's the elephant in the room, so to speak. I want you to get your comments on that. So Dick, and then Malia, and then maybe a comment on the election.
Yeah, I put in the chat a link to what many people have seen is the White House tape of John Ehrlichman explaining managed care in 1971 to Richard Nixon. And it's got this great line in it in which Ehrlichman says, well, the less care they give, the more money they make. And Richard Nixon says, not bad. And, if a company like corporation like Kaiser gets a reputation as treating sick people well, then sick people are going to gravitate to Kaiser and it will go bankrupt. The last thing any insurance corporation wants is to get a reputation for treating people well.
Yeah, that's a great example of why I would call this system perverse. That is the exact opposite of how you would want a model to function.
Thank you, Dick. And thank you for staying in the fight. I know that you've stepped back from the legislature, but New York may be the first state to adopt Medicare for all at the state level. So thank you for staying in the fight. Appreciate you. Malia, and then a quick comment on the election, perhaps, and wrap this up. And Ed did drop his contact information in the chat, so people be sure to grab that for any sort of follow-up questions or ideas you might have to share. Malia, quick question.
There are like 4 states that already allow people to get out of Medicare Advantage after a year. What kind of strategy, or is there any for other states to follow? Number one. And number two, just a comment on Kaiser, since I'm in California. First of all, there is a movement in Northern California and led by a physician to have single pay. He's part of PNHP, and to have single payer discussions. No, that's number one about Kaiser. Number two about Kaiser, you know, one of the reasons they may be able to say they're a nonprofit is they've bought Geisinger Clinic. They're expanding out of California. So that's what they're doing with their money, besides paying their C-suite an inordinate amount of money.
Yeah, you're right.
Question
So
about states.
Yeah, so I've looked into this quite a bit because, right, I mean, I thought that would be something I could maybe get to pass in Missouri, guaranteed issue and community rating. And just to be clear, so we're all on the same page, you can always get out of Medicare Advantage and go back to traditional Medicare. There's no barrier to that during, I think you have to do it during open enrollment, but you can always do that. The problem is that, you know, Medicare has such a high co-insurance and deductibles, you know, and co-pays built into it that if you want to be in traditional Medicare, most people do the arithmetic and decide that they can't afford that risk, that financial exposure, unless they can get Medigap. They have to purchase Medigap, and then that largely eliminates the copays and deductibles. So most people are reluctant to go into traditional Medicare unless they know they can get Medigap. And Medigap is only, the ACA did not include no pre-existing condition protections into Medicare. So most people don't realize that. They think that the pre-existing condition protections in the ACA are all across the board, and they're not. They disappear at age 6 when you go into Medicare. So for even before the ACA, when you go into traditional Medicare, you're guaranteed that you can buy Medigap without a health survey questionnaire, without any problems with pre-existing conditions, and at the community rate. They can't charge you more for yada yadas. But that protection only lasts for the first 6 months that you're in Medicare Part B specifically. And then that 6-month protection is extended to 12 months if you're in Medicare Advantage. So there are 4 states whose state Department of Insurance have, or the state legislature, I guess, have made it so that those protections of guaranteed issue from Medigap and community rating, fair pricing for the community price, is extended for your life in whenever a Medicare policy is sold. So in those 4 states, you can migrate back without a problem. And so I was thinking, well, heck, I want to do that here in Missouri where I live. And so I looked into it a little bit more before we sort of jumped on that and discovered a few things that made me abandon that as a strategy. The first is that the states where I looked at the states where they have that. I tried to compare it to the states that don't have that, but were similar in all the ways that I could figure out. And there was no pattern of a difference in Medicare Advantage penetration. So the states that have those protections did not seem to materially reduce Medicare Advantage adoption. Well, that's the whole reason I wanted to do it. And then also the states that did have those protections seem to have higher premiums for Medigap. So that's why I'm not convinced that. So I abandoned that for my own personal advocacy work, and I'm not convinced that that's a thing that we should, you know, adopt the mantle of as something to spend any organizing resources on. And that's why in the level of the playing field bill that we're talking about, what we're proposing is to just is to put in an out-of-pocket maximum. There is no out-of-pocket maximum in traditional Medicare. There is in Medicare Advantage, but there is not in traditional Medicare. So introduce an out-of-pocket maximum at the least, have it be the same as you have in Medicare Advantage, and that's still egregious. That's that's statutorily as high as about $12,000 or $13,000 a year. And most realistically, MA corporations have about a $5,000 out-of-pocket maximum. So at least do that, but that's still pretty egregious, and that's hard to rally around. $5,000 that's not what we want. So we want to organize around a $1,000 out-of-pocket max, and knowing that most of the people that's still a lot of money for would be covered by dual eligibility. So a long answer to your question, but sorry. If I could, the politics, you wanted to ask me about the presidential election.
Yeah, let me frame it. Let me just frame it for you real quick. There's a twice a week call here. You may be familiar with Democracy Partners. These are old time organizers. They brought in some Biden folks who did some focus group testing.
You
Really
froze
big
up.
piece. It's given the people's sense of loss of power, loss of control, that's a frame that they're leaning into very hard. And so my question for you, and the question we entertain at One Pair States, especially with regard to our state-based Universal Healthcare Act, is how do we infuse this into the campaign narrative, right, into the 2024 election intentionally? You know, keeping that, you know, that this is an opportunity to platform our issues, given the lack of discussion, the dearth of discussion on healthcare and healthcare justice issues. What are your thoughts, Ed?
I think you're exactly right. I mean, we're a C3, you know, we're a nonprofit C3, so we can't say this president would do that and that, you know, don't vote for this president because they would do this. And, you know, we can't do that. But I think what we can do is, you know, short of that line, you know, make sure people know, you know, this is, you know, you don't want to lose, you know, look at your candidates. You don't want to lose this. You can actually compare. Here's one platform, here's another. And so I think you're exactly right. Loss aversion is a very powerful behavioral economics message, and you know, inside and outside of this issue. So no, I think you're right. I think we need to that's why I was saying change the narrative. That's our whole goal for the 2024 open enrollment season, is to change the narrative. So the kinds of things you're raising are not lost. I mean, I mean, journalists want a good fight. They love covering stuff. So we've got to give them the material to make this the cat fight that they cover and have it be, you know, represent our point of view. Can I just ask, the things that I suggested, the Be a Hero training and the other things, the day of action in September, is that stuff that's resonating with all y'all? Is that something you think you're going to want to engage with?
Yeah, show of hands. We can open up the room mic just so that we can see all hands. Yeah, that'd be great. And then just a closing comment, Ed, and we'll have you back soon again, because this is a work in progress. We are really happy to be tethered with you, and also I'm really thrilled that you and Phil landed on this idea of really what we call radical visualizing, right? Which is actually seeing our success in the future, keeping that at our focal point, and then reverse engineering and understanding how did we get there. It gives us a positivist, it gives us a hopeful view of what it is that we all need, want, desire, and then it keeps us more centered, I think, in our energy. At least that's what I've discovered. So look forward to working with you on that as well. And thank you so much for coming here today. Any closing comments? Thank you.
Yeah, I mean, I think radical envisioning is exactly the right way to be thinking about this. That without that, you know, it's been discouraging to think that Teddy Roosevelt campaigned on universal health care, and here we are more than 100 years later without the bill being passed. And so, you know, if you think, oh, we don't have the bill passed, you know, this is dreadful, you know, we're like, no, think about the steps to get there, you know, and from an OPS perspective, you know, if you get a state that actually passes it, I mean, that'd be something that y'all could really celebrate, you know. And there's all these other things I just laid out. Keeping the Medicare Advantage rate frozen is not unrelated. It's actually instrumental to fighting the privatization and the profiteering, which we have to do, have to erode the business case for profiteers in order to get them out of want to leave the picture so that we can get to what we want to get to. So yeah, you're right. You know, think about the steps along the way and celebrate those pieces, because it's, you know, it's great fun. Thanks for inviting.
Thank you, Ed. We'll stay in touch. All the best. Stay cool. Okay. All right. Okay. Mike, do you want to open the room? Can we just to see if folks have any, I just want to just touch on a couple of business pieces for One Pair States, and just so that folks know what we're up to, and that Ed didn't lay it out in the program per se, because there's not unanimity within PNHP in terms of supporting what we call Medicare for All through the states, right? The State-Based Universal Healthcare Act. That's HR 6270. If somebody wants to drop that in the chat for people not familiar with that legislation, that's a bill that's being carried by Ro Khanna, introduced last November, and Ed Markey will be introducing it soon in the Senate. This is a huge, huge, huge step for us. And we see these issues as all, as Ed said, all interrelated. We're very agnostic as One Pair States. We've been around since 2009. You know, for 15 years, we were in conversation with one another on the telephone until we got Zoom, and then jumped over to that. And we've been much more intentional and focused in creating work groups, and being focused now on getting this legislation through Congress for the first time. I moved to Washington, D.C. I voted with my feet. I realized this is the place I need to be. So I'm your contact on the inside. If your member of Congress is not yet signed on with any of these bills, including the State-Based Universal Health Care Act, let me know. Let's go to work on that member. We need to educate. We need to push people along to understand that we've got tremendous opportunities at the state level. New York is looking very promising, I think, right now. Once we get traction with the municipal unions, I think that's really a huge challenge for us, but a great opportunity. And then Oregon and Washington and California and Minnesota and Maine, Massachusetts are all states that are pivoting to adopt universal healthcare systems, especially if we're able to get that legislation, that enabling legislation that would bring the federal healthcare dollars back to the states, allow them to create a single payer pool at the state level, and then model a successful universal healthcare system. And as many of you know, that's the way Canada was able to get to national Medicare for all, through the modeling of such a system in Saskatchewan. Tommy Douglas, the Tommy Douglas story. You all know this. So we study our history. I'm an historian, college professor, organizer. We bring all these folks together and we have these conversations about strategy, and the recent conversations that we had at the Healthcare Now conference have begun to really resonate, this radical visioning of what it is that we need, what we desire, and what we're going to accomplish. And in fact, our language is, how did we accomplish it? Saying past tense, how did we accomplish it? With the idea that we were able to do so, and then track through the different steps. Let me just throw it open and ask folks to support the work that we're doing. Anything you can contribute on a monthly basis, on a one-time basis, it goes a long ways. For many of you know, I'm living on a Social Security check and a pension check. I just need to cover some of my expenses here. So whatever you contribute to the organization goes a long, long way. So just know that that's really, really important for the work that we're doing. And it's unique in that we're the only organization with a dedicated single payer lobbyist educator in Congress, work in the halls of Congress. So thank you for the support that you give. Any questions that folks have from today's meeting, anything I've just mentioned, any announcements, any good news? Everybody got the links that you need for the upcoming activities for PNHP. Bill Semple, your hand is up.
Yeah, Chuck, thank you. And thank you for all the work that you're doing. And the question I have is, I think I read a few weeks back that the Congressional Progressive Caucus didn't even include improved Medicare for all in their platform this year. Is that true? And do we need to take mention of that? And does that speak to changing the narrative that we've been hearing about today?
Yeah, the short answer is that this is they're projecting for the 2025-26 legislative session. And that's based on the assumption that the Democrats hold the White House, hold the Senate, and retake the House. That's the premise. And the way that the CPC, that's the Congressional Progressive Caucus, operates is they have 5 what are called anchor bills. And these are their 5 top priority bills. And in the last 3 sessions, the Medicare for All bill, Jayapal's Medicare for All bill, and Bernie's Medicare for All bill in the Senate have been those top 5 priorities. I'm not going to take the view that they've stepped back from that. I'm just going to take the view that that we need to continue the work that we're doing. We're not going to get this done unless we create a massive movement on the outside anyway. The reality is that we have 112 members of Congress, voting members of Congress, and they're all Democrats. That's just over half the Democratic caucus. We're working on winning over Republicans to the State-Based Universal Health Care Act. I know that for a lot of people, they view the Republican Party as a monolith. I'm here on Capitol Hill, and I'm telling you, it's not. We can peel people off. Lisa Murkowski and Susan Collins were in conversation with them on the Senate. On the House side, we're in conversation with my former member in Bucks County and 2 members in Oregon and beyond. So we want to go into the next session hopeful that this election turns out in a positive way, a pro-Medicare for all election. It's like the way we can put it. We don't have to put a D or an R or anything like that around it. But the idea here is that we want to go forward with bipartisan legislation. That's part of the challenge here is that the Republicans come back into power eventually, and they're going to want to undo it. But if we have Republican buy-in and support, and we're able to frame it in a way that makes sense for their constituencies, look what's happening in rural America. Look, what's happening with the opioid addiction. It knows no political party. It knows no geographical boundaries. This is common sense. We know that we're in a cultish situation, with the GOP right now. We recognize that. We need to get through this. We need to get through this together and get on the other side so we have a rational conversation about how we actually build out a healthcare system that our country desperately needs. And we all know that the only way we can fund and finance that is through a single payer system. So I hope that answers your question, Bill. The CPC is a conversation right now, and I'm still wanting to get to the executive director there and understand what their thinking is. But I have been with Pramila Jayapal a couple of times, and she said that she's not backing off 1 inch, and Bernie Sanders has said the same thing. Having said that, she was also on a call the other day, Pramila, and she said the state-based Universal Health Care Act that she ran before Ro Khanna, she sees that as a very, very powerful tool for getting us to national Medicare for all. She has said herself that she believes that the states are the likely place where we're going to get the action and the movement toward a national solution, modeling it at the state level. And she went on quite at length in talking about that, and with great pride for having carried that bill before, again, handing it off to Ro Khanna a few sessions ago.